wanted to ask is, Smita, Kate, Bonnie, I'd actually like I'd like to invite you to respond to each other. I think you've actually done a nice job of building on each other. So is there anything you want to add that actually builds on what each of you have said? And then we'll turn to the chat box for a question. So Smita, do you want to go?
Yeah, thank you. Yeah, no, that's a very encouraging discussion, and I really appreciate Dr. Tam's report of, the equity-focused report, rather, or equity-directed report, talking about the structural and the systemic issues. And when we talk about those, we need to Bonnie talked about the access to the data. I will share a just small piece of data from the Bridge Engagement Center's previous project. We conducted a prompt project. We call it prompt because of before that, the project, which was PROUD, collected data on all the socio-demographics, legal issues, and housing issues, and mental health issues. And what we learned that about 96% have tobacco dependence. They smoke cigarettes. And by looking at that data, people themselves were shocked because we live in a capital city of a rich nation, Ottawa, 2 blocks from the Capitol Hill. We see the population difference so much because in Ottawa, we have the lowest smoking rate at 9%. And when you come 2 blocks away, it is 96%. With that inequity, people's eyes were open and they were so shocked, they wanted to take tobacco head on. So the question came from them. So when we took tobacco head on and found out that how best we can tackle this in the community in partnership with them, we had a partnership with the CMHA nurse coming there twice a week. And with that kind of a community partnership approach, we saw people not just reducing tobacco, but also all other drugs by themselves, and also improving their general socioeconomic, getting better job, better place to live. And this population, I am telling you, who had that 96% tobacco dependence rate, also had 7-8 times more mental health issue than the general population. And this demographic, these statistics we know well before this pandemic hit. So mental health issue about 8 times more, food insecurity in about 80% of this population, and vivid statistics we have from pre-pandemic. So those are the statistics we need to keep in mind and then understand what this COVID pandemic must have done to this very population which belong to the same very rich nation. And expand on that mental health issue and food insecurity. When the doors were shut of those agencies, those community centers, the bridge had to be closed down for a few months with the restrictions. The food bank is not there to go for. The friends that they hang around in the park are closed. You can imagine the mental health crisis. And when you have that statistics, and if we do not have equity as a lens and partnership as our tool, we will not go anywhere from here. And that's what we need to build on. That kind of a partnership to bring equity, to bring those voices which matter. The voices that with lived experience who bring that wisdom to the table. And that's the kind of partnership we need to cultivate to burst those structural and systemic challenges.
Thank you. Thank you so much, Smita. I'm thinking, Kate, you might have something that you want to say in response to that. And there's a question in the chat box that I saw, and you might want to kind of try to address that, is how do the voices, as Smita so eloquently and passionately said, make it all the way to boards of health and to those tables? So go ahead with your response and then maybe try to tuck that in, because I'm sure you've got some ideas.
I do. And I mean, Smita, I find your work very inspiring, being really driven by the leadership of community. And that's, that I think that there is beginning to be a cognitive shift at the systems level to recognizing that a deficit-based approach to inequity is never going to move the needle. That there are actually huge strengths that communities have to offer. And not only are they huge, they're really the only things that can make change in a sort of a complex adaptive systems approach, which is what we really need during a time of a syndemic. And I think some of the key drivers for that over the past year have been data and transparency. We can't make this shift, and our group had this conversation before this, before today, that we can't make the shift on values alone. And we may have a lot of shared values within the group of folks who have been doing this work for a long time. But what's moved the needle is sharing the data and sharing it as transparently as possible. You know, starting with the disaggregated socio-demographic and race-based data, you know, moving to neighborhood level percent positivity, moving to declaring workplace outbreaks and making sure workers are informed before they enter into those workplaces, and so on and so on. And so that even the fight for transparency to meet, to have oversight, to ensure the board has a role, those are all are really critical. And so transparency in representation is also going to be a key frontier, that our own board does not have any Black or Indigenous members. This does not reflect the makeup of our city, nor does it reflect those who are disproportionately impacted by socioeconomic conditions and so on that lead to barriers to good health and well-being over generations and over geographies. So those are all, I think that the more open we can be about what we are doing, about who we are, who's doing the doing, and about what data is driving it, that the easier it will be to see what the next steps must be. If we're transparent about representation, if we're transparent about the data, that should guide good decisions. And when it doesn't, then the other factors that are guiding decisions become a lot more clear. When we have the data and we see decisions that appear to contradict the data, it guides our questions, it guides our decisions as communities and as leaders. And I think that's really important feedback as well. And as practitioners, when we get the feedback, we act on it in a learning health system environment. And I think that that's only going to help us going forward.
Thank you, Kate. And I think that notion of or concept of transparency, and then I think at the end there, you're speaking about accountability, right? So once you hear it, once you see it, being accountable to take action and not just trying, right? But continuing to push forward in real action to make that systemic change. And it's hard work, but it is doable. Claire,
yeah,
I'm going to ask.
Sorry, Claire, just before you went, I just wanted to add that, I mean, that accountability is really what it means when we say health equity is never implicit. We have to raise it, we have to surface it, we have to be held accountable for it, and we have to hold others accountable for it. And there have been times at the board when I've asked questions and received the response that, well, that's implicit. And I always challenge it because it needs to be explicit, and we need to have that accountability.
Very, very nice, Kate, and an excellent sort of final statement to that. Claire O'Gorman, I'm going to ask you to watch for a question because we will have time for a question. But Bonnie, I'm sure you've got something you might want to add from your perspective to what Smita and Kate said.
Yeah, thanks, Claire. And Smita and Kate are doing incredible work at the community, and I just love listening and lapping it up. And I like where you're going about the importance of data and transparency and community partnership to really inform change. And I guess I would want to add to that I also see and feel acknowledgement and energy around stigma and discrimination in our systems that really help us, as we have data and we are being transparent, and it calls for a little bit more accountability. But as we have campaigns like Black Lives Matters and the Me Too campaign and Indigenous Lives Matter campaign, I think we also see the importance of social cohesion and the real call to address stigma and discrimination in all of its forms, as we see through through this pandemic, like ageism and sexism and classism. And that is also really helping us address some of these fundamental issues that are so necessary for this accountability to a health promotion, health protection approach. And I was just thinking about that when Kate and Smita were talking about the things that really move the needle. And to me, it's when there's that large gathering of that community voice that really comes in holding us to account with racism and sexism, and being able to directly speak to it out loud so that we can begin to or continue to develop our cultural approaches to addressing stigma as well. So that's what I wanted to add, Claire.
Thank you, Bonnie. And I'll just draw attention to the annual report of the Chief Public Health Officer prior to this one. So in 2019, actually addressed stigma and discrimination. And this report in October of 2020 built on that. So it's important reading, and it's an important resource to us as we move forward and take action. So Claire, I'm going to ask you, O'Gorman, to open your mic. You might want to say just who you are and where you're sitting. And then if you could ask on behalf of the participants, there's been lots of activity, and keep that up, please. Your comments, your ideas, if you want us to reach out to you, if you've got examples across the country where things are working, where equity is explicit and right there, please talk to us in that chat box, please. So over to you, Claire O'Gorman.
Hi, everyone. I'm a knowledge translation specialist here at the National Collaborating Centre for Determinants of Health. I'm based in Treaty 7 territory in Calgary, Alberta. And I'm seeing some really great conversation in this chat box. So thanks for everyone for your contributions. It's really valuable, and would love to connect with many of you offline about the fabulous work that you're doing to forward equity work so that we can continue to lift those stories and lift these voices, lift your voices. So I'm seeing a lot of conversation about how we bring forward different voices and diversity to the decision-making tables, and ultimately how those decision-making tables and those partnerships that we form with community actually work on and make the structural changes needed to move towards equity. And that's a big question and a big undertaking, but how do we move that whole process along, get the voices at the table, reinforce and support those voices at the table. And, often it's a lot of volunteer work or it's unpaid labor. And then how do we take that and move it towards structural changes that are needed and the opportunity here in COVID. So Dr. Pakhale, I see you raise your hand. You have something to say about that.
Thank you so very much. That's a very important question at the end of the day, how we move this forward. How do we make equity as a new normal? How do we hold each other accountable? How do we bring the accountability and transferee to the surface and not as one of the rule and implicit? So this is where that true partnership comes in a picture, because right now we have a democracy. But I would say, really, what we need to have is a participatory democracy. We need to have participation of citizens, of day-to-day citizens with lived experience, may it be mental health issues, may it be challenges of schooling, may it be challenges of whatever their local issue is. Participation of those citizens at each of those tables, from their community level to their city level, to their provincial level, and to the federal level. And that kind of a meaningful participation of the citizens unless until it is there, we are not living in a participatory democracy. Because by bringing those voices to that table where it matters, that decision making where the policies are being made, if those policies are not relatable to that citizen living in that community, what good our policies are? And even if those policies are made, if there is no funding attached to that policies, what good that policy is? So unless until we hear from that citizen at that table, and whatever table that may be, howsoever big that table is, that lived experience, that voice has to be incorporated in a meaningful way and not a tokenistic way. We many times include citizens in a tokenistic advisory board. Oh, we had citizens involved in our advisory board, and then we did everything else because we are the expert, right? And that kind of a top-down approach we got to get rid of, and we have to have this integrated, truly meaningful participatory approach in every level, and that's how only we will make equity as our new normal.
Thank you, Smita. So Kate, Bonnie, do you want to build on what Smita said in terms of answering that very large question from Claire?
Yeah, I mean, I just really want to support what you've said, Smita, and to say, I mean, this has been a big part of my work, my day job, with working with community health centers, trying to get them represented and their communities represented at decision-making tables. But also with respect to the Board of Health, I joined the board about almost 2 years ago now. I had experience working with Toronto Public Health, and I still found it a very overwhelming experience. There was no onboarding, no training. I didn't really know what was going on. And the overwhelming feeling was that I was there to be seen and not heard. It took me a few meetings to kind of get the understanding of how it was working, what I was supposed to be doing, and what kinds of questions I could be asking, what kinds of things I could be doing. And then I found my voice. And that's been, you know, I've been sort of really focused on the health equity and the community components of the work ever since. But I came in with quite a bit of that privilege and still found it quite overwhelming. And so we need to focus on onboarding. The board does pay a stipend to public members for their participation. It doesn't do the same for the politicians. And so it has made some effort to ensure that people are recognized for the time that they are giving to the works. I think that's really important as well. But it's a political process, the public appointments process. And I think, again, that's where the explicit accountability needs to be. If we're not explicit about who needs to be at the table, we're going to replicate the same patterns that we've always replicated. And it's sort of like a horse trading amongst political orientations is how that works. So that's the example from the Toronto Board of Health. We definitely need to have representation across the board in those decision-making roles. One thing that works well is that we have direct deputation by everyday people, residents of the city, and they can be quite influential. So anytime, and even now in the virtual meetings, any resident can make a deputation about whatever's on the agenda. And you get 5 minutes to have your say. And it's been really important to have that kind of direct participation that doesn't happen at other levels of government. So those are a few things that are working well that we need to keep working on at that sort of municipal level.
Thank you, Kate. Those are excellent points. And so, Bonnie, I'm going to give you a chance to build on what Smita and Kate said. We're coming around to 50 minutes into this, so I'm going to actually cycle back to the speakers for some final words, unless, Claire, you hear a critical voice in.
So Claire, I'm having some internet challenges. So if I drop off, please forgive me and keep going. And so I caught little bits of what Smita and Kate said and really appreciate their comments. And I can totally relate working in a federal government context, which is, a massive bureaucracy. And just one of a couple of things that I think about in this type of system as well is how to sustain some of the really great steps that I see around moving forward. And so I saw someone in the chat box talk about peer payment, which is so critical in having lived and living experience inform our work. And there's been lots of work at the Public Health Agency as well as Health Canada to really institute a policy that will support living experience in the right way at the table, you know. So, you know, a great example was we were able to give honorariums and payment for work that it was contributing to, it was substance use harms policies moving forward. And then one of the things that we didn't even think about is when we invited a colleague to speak at a conference, I received a call late at night in a panic that we've just come to the hotel and they require a credit card to hold a room. And so, like, we need to think through all of the ways that we can support a critical participation. Like one of the other advances that I do see is a real interest in senior level people to be able to have invited lived and living experience voices in the role of committees and task groups that are created as well. And so again, I think that we have a long way to go in really improving our systems. And I keep thinking about developing sustainable mechanisms. And so trying to get some of these steps forward instituted as policies so that we can be accountable and accountable to real voices at the table. Yeah, so that's what I wanted to add to the conversation, Claire, and don't want to take up too much space.
Okay, thanks, Bonnie. So I'm just going to check over there with Claire, and we would be moving right now to some final words. Claire, is there one thing that might spark some final words from Smita, Bonnie, and Kate?
Well, this one's one that, as someone who's previously working in a health authority, resonated with me, and that is, how do you engage in advocacy? How do you lift these voices when you work internally for the organization that's perhaps funding you, or you're personally funded by the entity you're critiquing or aiming to change? And how do you work within those systems to move an equity agenda forward and ultimately seek justice?
Thank you, Claire. I think that's an excellent way to sort of round out our conversation. I'm going to go Bonnie, Smita, and end with you, Kate. And so this kind of give your final words, but I'm going to ask the folks that are online, if you just, while we are closing off here, we're at 54, it's about 6 minutes to the top of the hour. If you could do what we asked 2 weeks ago, just kind of put in one word that's percolating to the top of your mind. We have more than 160 voices online. We'd love to hear that one word in the chat box. I also want to point you to a recent Let's Talk document that we have produced at the National Collaborating Center for Determinants of Health on community engagement. There's also a product that we developed in partnership with the National Collaborating Center for Infectious Diseases that actually has a framework for organizational indicators around, public health organizational indicators around emergency preparedness, that we've actually added equity prompts. Much of what has been said today, both in the chat box and by our speakers, resonates there. So check that out. It's on our website. And I just really want to invite you to our next conversation, which is on March 10th, 2021, same time, a Wednesday at 12 noon Eastern time. And we're going to look at those policy windows, because there are policy windows wide open to us right now. So policy windows, advancing health equity through COVID-19 recovery is the title for that session. So Bonnie, to you, hope you can remember what Kate's question was, and then Smita, and then final word to Kate. Thanks. Bonnie?
So I understood Claire's question to be, so how do we move this forward when we're working within the system that might not be supportive of what we're trying to move forward? And I go back to what both Kate and Smita said before, and it is with data and transparency. And what I would add is to be really able to speak in ways that your audience can hear. So there are times when we need to provide, long rationales, but if you're presenting to senior leaders, what is really important is to speak to what is needed and really answer questions directly so that you show the benefit and the critical importance of where you need to go. And so I would say that is one of my big learnings. And I also worked with Dr. Teresa Tam, who is brilliant at being able to really tailor her message internally so that she is heard. A little bit of a CPHO platform also helps, but she is great at what she does. Thank you.
Yeah, thank you, Bonnie, for that. And just a reminder to the group that's online with us, Teresa Tam asked us for ideas, so I also know that she's wide open to that. And again, you can just email us at nccdh@stnevex.ca or Claire directly, or you, Bonnie, and we can certainly lift those up. People are actively putting their words in the chat box, and what I'm heartened by is they're different words than what we heard 2 weeks ago. So, Smita, your final words, and then Kate.
Thank you. I just wanted to bring back to the point of how some people ask, and Bonnie brought the point like how they face the difficulties of involving peers, we call community peer researchers. And we have actually operationalized the method, how we do it, and how equitable way we do it, how we bring down the power dynamics as much possible, because I'll always be the physician and I always be that, because that I cannot change. But that our model called Ottawa Citizen Engagement and Action Model, and thank you, Claire O'Gorman, putting the link in the chat box. Please take that model, make it your own, pleasurize it, adapt it the way you want it. If you have any questions, please call us back. We are always ready for collaboration. But what we want to see that people with lived experience are engaged in a meaningful way. They are compensated for their time, transportation, and efforts with real money, not credit card, not cards, real money. And we navigated that through breaking a lot of systemic barriers in OHRI, in the institution, the ivory tower that I am associated with. So we got to break some systemic barriers to make that happen, to give them real money. So that kind of a effort we need to do, and I will not minimize it for one bit. It is not easy. It is not, without challenges, but it is very, very rewarding. So that's the how part. What my final word is, I urge you all sincerely that we should not go to pre-pandemic. Everybody is urging to go pre-pandemic, the normal. I urge you not to go to the pre-pandemic. We want to envision social cohesion, and we want to bring out structural and systemic change. We have to make participatory democracy our living and breathing thing, and then only we will create the structural and systemic change and bring about that social cohesion with that common community vision towards that same goal.
Thank you. And that is a very, very passionate call to action. Thank you for that, Smita. Kate, and then we'll close our session.
We are all parts of systems. We are all parts of institutions. And for those of us who are being paid by some of those institutions, it is further complicated, but we all have a role to play in really making transparent, making explicit those structures and those accountabilities. And for me, the way forward is to learn from and lift up the example of those people who are leading by example at the community level. And that's where I see a lot of promise going forward.
Thank you. Thank you so much, Kate. And I'm reminded, I was attending an online session recently, and someone said about similar topic to this one. And she said, there's a fight going on and I can contribute. So there is a fight going on and we all can contribute to it. So thanks everybody. I'm looking at your comments there. Thanks everybody for giving us your time today, the gift of that time. And we'll see you in 2 weeks. Thank you so much, Smita. Kate, Bonnie, for being here today with us and contributing in such a good way. Thank you, everybody. Have a great day, and we'll see you in 2 weeks. Bye now.
Thank you so very much for organizing.
Bye.
Thank you, everybody.